Hi, this is Dr. Mahadevan, and today we're going to be talking about advanced airway management. This is part 1 in a series of 5 lectures. And our lecture objectives for today are first to talk about the indications for advanced airway management. Next, to talk about specifically the procedure endotracheal intubation, the advantages, disadvantages, and complications of this procedure. And then finally, to spend some time discussing the technique of endotracheal intubation. So when we're talking about advanced airway management, oftentimes it's arguably the single most important skill taught to and possessed by emergency physicians. It can be life-saving for a patient, and so it's something that we need to learn, relearn, and understand in order to provide this procedure to patients in need. What is endotracheal intubation specifically? It is passing an endotracheal tube through the glottic opening. Here is the glottic opening, and into the trachea, and then inflating the cuff on the tube so that it rests against the endotracheal wall and forms a seal, preventing the leakage of air and also aspiration of gastric contents into the trachea. And once this is done, advanced airway management really encompasses endotracheal intubation and then providing adequate oxygenation and ventilation. What are the indications for endotracheal intubation or advanced airway management? They are namely to protect someone's airway if they're unable to maintain it, is to provide oxygenation or ventilation if someone is not able to do so. So if they have respiratory distress and their oxygen saturation is low, or if they're retaining carbon dioxide, this would be a reason to provide advanced airway management. Some patients have the potential for deterioration based on their clinical presentation. I'll give you some examples. A gentleman or a person who's been stabbed in the neck and has an expanding hematoma may have a normal airway for the moment, but over time as that hematoma tends to expand, it's going to distort the airway. So you might provide advanced airway management. You might endotracheal intubate this patient early to prevent the complication of that airway distortion later. The same is true for someone who is in a burning building and inhales heated air and then develops swelling of their airway. Their airway, again, may be normal at the moment, but over time it's going to swell and then close shut. And so you might intubate them or provide advanced airway management now while their airway is open and before this complication arises. And finally, sometimes we intubate patients for their own safety and protection. Take, for example, the intoxicated trauma victim who might have a cervical spine injury. They may be thrashing about and may make their injury worse and potentially even become paralyzed as a result of their own actions. In a case like this, we might put this patient down and intubate them until we can ensure that they don't have some kind of potentially life-threatening injury or injury where they could become paralyzed. So we would also intubate patients for their own safety and protection. These are the indications for advanced airway management. So let's take a look at this patient and listen to her. And as you can see, this is an elderly lady who is making a lot of noise and struggling to breathe. And generally, what you notice about people in general is that you don't hear or see them breathing. When you could hear or see someone breathing, that generally indicates a problem. And in this particular instance, not only can we see her struggling using the accessory muscles in her neck to try and generate negative pressure in her thorax and breathe, but you can also hear really noisy respirations. And in this particular case, she's really struggling to breathe, she's failing to ventilate, she's failing to oxygenate, and therefore this lady needs to be intubated. What are the advantages of endotracheal intubation? The first is that it provides a patent airway. When I say patent, I mean open. So it provides an opening between your lungs and the outside environment that can't collapse. Number two is it protects against aspiration. Again, when we insert the endotracheal tube and then blow up the cuff, that sealed airway is going to prevent contents from the stomach entering your lung and potentially causing damage and morbidity and mortality. The other advantage of endotracheal intubation is we can perform this procedure whether a patient is breathing or not breathing. And then finally, we have direct anatomic visualization during the placement of the endotracheal tube to ensure that it's going in the right location. So we are looking directly at the glottis, and we can see where the tube is going as we pass it into the patient's trachea. Disadvantages obviously are that it requires special equipment and training, but that is something that you can obtain. So examples of specialized equipment, this laryngoscope here, and these specialized blades, these Miller blades, which are on the bed. Complications of endotracheal intubation are very important, and one of the most important ones is unrecognized esophageal intubation. Sometimes, in 6 to 16% of endotracheal intubation attempts, the tube may end up in the esophagus instead of the trachea, and that's something that we want to recognize early and fix. Sometimes during the procedure, a patient may vomit and aspirate the gastric contents or the contents of their stomach. That is bad because it increases their chance of dying. As a result of the procedure itself, some patients can develop a slowed heart rate, laryngospasm, bronchospasm, and apnea, or they can stop breathing. If the procedure is done incorrectly, there can be trauma to the structures in the mouth, such as the teeth, lips, and if you're not careful as you pass the endotracheal tube, you can also injure the vocal cords. And finally, in trying to perform this procedure, generally you're hyperextending the patient's neck. And if they already have a cervical spine injury, you could potentially make it worse. And let me show you that again. During the process of endotracheal intubation, you tend to want to hyperextend the patient's neck in order to visualize the vocal cords. And in doing so, what can happen is you can hyperextend the neck. And if the patient already has a spine injury, what can happen, as we've seen before, is that you can create or worsen the injury. In this particular case, the ligamentous complex that's holding the vertebral bodies has been torn, and by hyperextending the neck, this vertebral body has moved posteriorly. And the reason that's concerning is that the spinal cord runs right here. So by hyperextending the neck, this bone can potentially impinge on the spinal cord and injure it. So we're going to talk about this several times, but there are 6 steps to endotracheal intubation that I want you to be aware of. First is preparation. Next is pre-oxygenation. Third is positioning. Fourth is placement. Fifth is proof of endotracheal intubation. And then finally, post-intubation management. And the way you can remember these are as the 6 P's of endotracheal intubation: preparation, pre-oxygenation, positioning, placement, proof, and post-intubation management. That's our first lecture on advanced airway management. Thank you very much.